Please just wait for 2-3 minutes because we are expecting many more people to join.
There is a message by Professor Chan in the chat box. I hope somebody has addressed it.
5 minutes.
Sir, I have already replied.
Yeah, it's okay. I will share from my side and present my lecture during my session. Thank you. I'm Stephen Chen.
Thank you.
Okay, so support team, can you hear me properly? Surbi, can you hear me properly?
Yes, sir.
Okay, so now can you please give the countdown, and then I will invite Dr. Vineet, sir.
Okay, sir. On my count, 3, 2, 1. Please start, sir. We are live.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this very exciting topic and session on biliary tract cancer. It's a great pleasure to welcome and invite Dr. Vineet Talwar, sir, Director, Department of Medical Oncology from the prestigious Rajiv Gandhi Cancer Institute at Delhi. Good evening, everyone. Once again, Dr. Vineet, sir, good evening to you. The floor is all set. We look forward for setting the context, please. Over to you, sir.
Thank you very much. So these are exciting times for the biliary tract cancers, where now we are having the immuno-oncology foray into the biliary tract cancers, especially the gallbladder cancer, which has been an unmet need. So I'll just give an overview. Next slide, please. So India, as compared to the other countries, the West has a very high burden of biliary tract cancers. So most of the cancers which we see, either there are in the Southeast Asia, India, or the South America, especially Chile and these areas. Next slide, please. But unfortunately, only 10% of the BTCs are resectable, as we have seen in our practice. So how to go about enhancing the effect, because as far as chemotherapy is concerned, the graph is almost plateaued. Next slide, please. And these are the NCCN guidelines, which are the pre-IO era, in which you could have a combination of 5-fluorouracil, platinum, gemcitabine, and sometimes when you had the MSI and the anti-RPG infusion positive tumor, you could have. Now the situation is changing. Next slide, please. So we have this phase 3 randomized double-blind placebo-controlled study of durvalumab in combination with the standard chemotherapy drugs, that is gemcitabine plus cisplatin, in patients with advanced biliary cancer, which was the Topaz-1 trial, which is a practice-changing trial, which I strongly believe. Next slide, please. And this was the overall recruitment from all of the countries in the world, and India was proud to be a part of the global clinical trial. Next slide, please. So myself and Vikas and Vineet Gupta and Jyoti Ghosh were there from India, representing and participating in the trial. Next slide, please. So this is the Topaz-1 trial, and without much ado, I think I will give the floor to Professor Stephen Chan. Professor Chan is the professor of the Department of Clinical Oncology of the Chinese University of Hong Kong. His main interest of research is clinical and translational studies on hepatobiliary and pancreatic and neuroendocrine cancers. He has published over 160 papers in peer-reviewed journals. And internationally, Professor Chan is serving as the associate editor for several journals, including the Journal of Hepatology, Liver Cancer, and Therapeutic Advances in Medical Oncology. He is also serving as the chairman of the Education Committee of the International Liver Cancer Association, ILCA, and has also served in the Scientific Steering Committee of the European Society for Medical Oncology Congress as the Tract chair in 2021 and the committee member from 2022 to 2023. And locally, Professor Chan is the panel member of Biology and Medicine panel for the General Research Fund in Hong Kong and has also established a charity hand in the Cancer Foundation to serve patients in need. So thank you very much, Professor Chan. It's a pleasure that you are joining us, and we are going to listen from the horse's mouth the trial, which is, I believe, supposed to be a practice-changing trial and which we'll be delving upon subsequently. So over to you, Professor Chan, please. Thank you.
Thank you, Dr. Tawar, for the very nice introduction. So let me take this opportunity to share my screen first. So could you see my screen? My slide?
Yes, yes.
Okay, thank you. So first of all, again, thank you very much for inviting me. Actually, I think this is my first time to speak for our Indian colleagues. So hopefully in the future, I will have more opportunity to learn from you all. So the topic today is the new avenues in the management of advanced biliary tract cancer. And our chairman has already highlighted one of the important trial, TOPAZ-1 study, which also I will mention in my presentation. So these are my disclosures. So I will use next 20 minutes to briefly walk you through these 4 areas. First, background, but I won't speak too many because I know our Indian doctors are very familiar with the biliary tract cancer, especially the gallbladder cancer as mentioned by our chairman. I will give you some update on the first-line therapy, followed by some new concepts or some data in the second-line therapy before I end my talk with some future directions. So the background, we know that actually biliary tract cancer is not the commonest GI malignancy. It only occurs in around 3% of all GI cancers, but actually recently it's caught a lot of research attention. I think one of the reasons is because we do see more biliary tract cancer, especially intrahepatic cholangiocarcinoma, which you can see from the US data or from the UK data or European data on the right-hand side. You can see generally there's been gradual increasing incidence of intrahepatic cholangiocarcinoma. We don't know the exact reason. Our chairman has already mentioned maybe the gallstones, the stone disease may contribute to some of it. But I think one of the factors is the metabolic syndrome, like diabetes, obesity, which also may contribute to those liver malignancy, including the intrahepatic cholangiocarcinoma. In terms of treatment approach, we already learned also from our chairman that around 10% patients are surgical candidate, and we now have some adjuvant therapy like the BioCap study suggesting the capecitabine in prolonging the overall survival and the disease-free survival. Unfortunately, 80, maybe 90% of patients are the inoperable candidate, and they require some form of systemic therapy. Although traditionally, we learn from the literature, some centers may also apply some local regional therapy, for example, the Y90 or even some HAIC for the intrahepatic cholangiocarcinoma, like we treat the HCC. And also we know our radiation oncologist told us that maybe RT may help some cases, although the robust evidence are still lacking. And also we have learned from some serious and some prospective study that photodynamic therapy may be useful in the extrahepatic cholangiocarcinoma. Although personally, I find the use of these type of local regional therapy quite variable, and is the use probably decreasing in the near future because of the advance of the systemic therapy. Then move to the first line therapy. We all learned from the UK ABC O2 study, which has established the gemcitabine cisplatin as the standard therapy for patients with advanced or locally advanced or unresectable biliary tract cancer. When you look at the overall survival, definitely it's better than the single agent gemcitabine, OS of around 1 year. But of course, this is far from satisfactory because we need better treatment for our patients to live with a median overall survival longer than 1 year. And also when you look at the response rate, is the partial response rate only around 1/4 of patients with responses. And also we learned from my experience that the response probably is not durable amongst those patients, even they respond to the chemotherapy. Anyhow, for the past over 10 years, this regimen has been the most commonly used regimen all over the world. And also, I think is also established as a reference control arm where we develop the first-line therapy for our patients. Are there any progresses in the past 10 years? There are some, but actually not many. For example, the Japanese group established the GEM-TS1 as a non-inferior to the GEM-cisplatin. And we also learned from these SWOG study, the phase 2 clinical trial, they use a triplet, gemcitabine, cisplatin, and adinab paclitaxel in the treatment of advanced biliary tract cancer. You can see from the waterfall plot and also from the response rate, it's quite impressive, 45%. And also you could see there's some patients with quite deep responses with a response shrinkage of tumor over 80 to up to 100%. But not surprisingly, this triplet regimen, chemotherapy regimen, is at a cost of a quite high, mainly marrow toxicity, with a 33% patient developing grade 3 to grade 4 neutropenia. Of course, this could potentially be relieved by the use of growth factor. And also you can see in this phase 2 study, the overall survival seems to be improved much better than the GEM-CIS in the UK-ABC study. But of course, we need to interpret this result with caution. It's only a single arm study. It may be a highly selected population. This is why this regimen is being tested now in a randomized study comparing to GEM-CIS. And hopefully in the future, we have a phase 3 readout to see whether this aggressive regimen could be used routinely in our patients in the first line setting. And our chairman has already very nicely alluded to a very important study, in my opinion, which is the TOPAZ-1 study. This study, actually quite a robust study, is built on the quite promising data from our Korean colleague. And then the sponsor and also the investigators has developed this phase 3 clinical trial. Basically, they included patients with ICC, extrahepatic, and the gallbladder cancer. The patient could have either recurrent disease or initial metastatic or local advanced disease. And the performance status 0 to 1. And the patient were randomized 1-to-1 ratio. And the control arm is the GEM-CIS plus the placebo, while the experimental arm is on the durvalumab every 3 weeks in combination with the GEM-CIS every 3 weeks up to 8 cycles. And after completion of the GEM-CIS, the patients also will receive the maintenance durvalumab if they have a disease control or even partial response from the disease, while the placebo arm receive the placebo therapy. And the primary objective is to demonstrate any difference, improvement in the overall survival, while other secondary endpoints are pretty standard with the PFS, response rate, duration response, safety, and also pre-planned analysis of the PD-L1 status impact on the outcome of the patients. I won't go into too much, bore you with all these details. I'm sure you can go back to the New England evidence paper, but we'll highlight several things in the baseline characteristics. First of all, you could see, actually it's quite a international study. Although 50% patient Asian, another 50% actually came from other parts of the world. I'm not sure if the Indian investigators, the site patient were grouped under the Asian. I believe so, but correct me if I'm wrong. And also you could see there's quite a well-representative populations with around 50% patients with ICC, around 20% extrahepatic cholangiocarcinoma, and 25% of gallbladder cancer. most of the patients have initial unresectable disease, and also most patients have metastatic disease, but there are also some patients with recurrent diseases and also patients with locally advanced diseases. Around 60% patients have the PD-L1 expression higher than 1%, while around 30% patients belong to the PD-L1 negative population. So this was the primary outcome of the patients. You could see it from the Kaplan-Meier curve. In terms of the median overall survival, there's been modest improvement of the overall survival, 12.8 months versus 11.5 months, with a hazard ratio 0.8, and also with statistical significance according to pre-specified p-value. But to me, the more impressive finding is that you can see after reaching the median overall survival, the curves continue separating between the experimental arm and the control arm. And you could see it result in, for example, in the landmark analysis, around 10% difference in the overall survival rate at the 18-month, actually close to 15 months at the 2 years overall survival rate analysis. I think this is a proof of concept that the continuation of the PD-L1 durvalumab could benefit the proportion of patient which is durable. And this is why you can see there's a continued separation of the survival curves. When you look at other secondary endpoints, for example, the tumor response rate, also there's a modest improvement in the response rate with around 27% patient having partial over-response from the combination, while only around 19% patients benefited, having a response from the placebo. And also when you look at the duration of response, again, you could see generally the experimental arm, they have a shorter time to the response and also slightly longer time of duration response. All these suggesting that these combination regimen are benefiting the patient with advanced biliary tract cancer. When you try to look at the subgroup analysis, generally you can see all the predefined subgroup, the durvalumab plus gemcitabine arm, they benefited all subgroup of the patients. Perhaps you can see some outliers. For example, in the region, generally you could see there's a trend that the Asian population, they tend to have more benefit from the rest of the world in terms of survival benefit. Of course, this is more hypothesis generating, but again, you can see the rest of the world, they also derive benefit. But probably there's some either genetic or tumor environment that favor better durvalumab response in the Asian subgroup. I think this is also observed in other liver cancer, like the HCC. And also when you look at the PD-L1, interestingly, although we do see a slight trend of the benefit favoring the positive PD-L1 subgroup, but also you could see the PD-L1 negative group also benefit from the combination. And therefore, I think at this moment, we could not rely on just PD-L1 expression to decide give or not to give. Basically, we need to give to our patient if they could afford or if this is a reimbursable regimen. Perhaps I will stop at this first-line therapy and move to the second-line therapy. Of course, we could discuss more later about how we interpret this TOPAZ-1 data. I think second-line therapies are very crowded or very interesting now because we're generally moving from the blind chemotherapy, empirical chemotherapy, more towards the personalized treatment. And because we understand from the molecular analysis or NGS data that some driver mutations exist in the cholangiocarcinoma, especially, for example, in a hepatic, we have seen a patient around 10 to 20% having these FGFR2 fusions, and also these IDH1/2 mutations. And also in the extrahepatic or gallbladder cancer, we persistently see that around 10 to 20% of patients are having these HER2 amplifications, which may also sensitize patients to the HER2 therapy. Also, there's also some other tissue agnostic marker like the Tract or the MSI phenotype or even BRAF, which will also subject our cholangiocarcinoma patients to some targeted personalized treatment. Perhaps this is a very busy slide, just showing you a snapshot of these biomarker or actionable mutation-driven clinical trial. On your most left-hand side, we have IDH1, which is ivosidenib. You can see, although the response is not very high, there was an overall survival benefit. And it's better than the standard second-line chemo, like the FOLFOX chemotherapy. And also in terms of FGFR2, we have a pemigatinib and ifligatinib. And I think there will also be some other FGFR2 inhibitor coming. All these showed in this selected population, there's a response rate around 20 to 30%. And this was also translated into improvement of the overall survival. I think also the HER2 therapy is very exciting now. Based on experience in the breast cancer and also gastric cancer, or even colorectal or lung cancer, we already have a plethora of a different HER2 therapy, like the combination of pertuzumab plus the trastuzumab, or some other new HER2 therapy on these patients. And also we have the drug conjugate. All these although the study is a single arm, small scale, but all these show a very high response rate, up to 40, or a high disease control rate. And also this seems to be translated into a survival benefit in this second line population, which is again, apparently better than the patient treated with the chemotherapy. So hopefully in the future, we'll see more data with these biomarker-driven clinical trial. Perhaps you may also ask, we also use the immunotherapy in the second line. Unfortunately, the data is not that, I would say, more mixing or not that encouraging. One of the data come from the pembrolizumab, which is a combined analysis of the Keynote 158 and the Keynote 028, which is a basket study. But when they look at the role of the single agent pembro in advanced biliary tract cancer, you could see, okay, you still see some from the waterfall plot, some patients responding to the disease, but actually not many, maybe around 10, 20%. And also when you look at the overall, overall survival and also the progression-free survival, is that OS is only around 7.4 months, and the progression-free survival is only around 2 months. This is actually quite a, I would say, not very impressive result if you talk about the single agent pembrolizumab. And also when you look at another study, which is it's a multi-center study of nivolumab in patients with a second or third line treatment of advanced biliary tract cancer. I think you can see the response rate is not very impressive. Central review only show around 10% patient responding to the treatment. And also, but the interesting finding is that they seem to suggest that the patient with a PD-L1 positivity seem to derive more benefit. But of course, this is a single arm study. We need to have a more robust, especially randomized data to see whether the PD-L1 is more a prognostic marker or really a predictive biomarker to the patients treated with nivolumab in the biliary tract cancer. But anyhow, I would say from these studies, single agent PD-1 probably is not very important, or I would say very effective in this setting. Then how about the combination? There have been one phase 2 study, I think it's by the US group, trying to look at the combination, the ipilimumab together with the nivolumab, the CTLA-4 and the PD-1. You can see the response rate seems to be better, now up to 30%. But this also at the cost of a higher immune toxicity, although they reported grade 3 immune AE around 50%. But I think when you use more generally in the population, perhaps we will see more IRAE in this population. And also this seems to be also translated into some improvement in the survival and resulting in some tail. But whether this regimen is could be routinely used in the population, I think again it requires some validation study. Maybe it can be used now as an off-label or in some really heavily pretreated patient while they're still fit for the immunotherapy. Last but not least, recently there have been one China study. Although it's published not in not a big journal, but actually when you look at the data, it's quite impressive by use of the pembrolizumab together with lenvatinib in the refractory populations. You can see the waterfall plot seems to be better than the single agent, the PD-1, nivolumab, pembrolizumab. And also when you look at the OS in this heavily pretreated group, it's close to 1 year. Fortunately, we don't see any phase 3 data now. I know the MSD probably having some basket study of this combination in the biliary tract cancer. And hopefully in the future, we can have more international robust data to see whether this regimen could be generally useful in the larger populations of advanced biliary tract cancer. So probably I will move to the last session, which is the future. I think you already learned there's a lot of excitement about the targeted therapy, immunotherapy in the biliary tract cancer. Currently, in the first-line setting, we already have at least 3 clinical trials on the use of the FGFR2 inhibitor, TS120, infigratinib, pemigatinib, versus the standard GEMCIS in this FGFR2 rearranged population. All these studies are ongoing, although I think they see a challenge of recruiting adequate number of patients, because only around 5 to 10% patients in the real world have this FGFR2 fusion, and may take quite a long time to recruit these populations. And also, I think there's some study talking about the combination, similar to the TOPAZ-1 study with the GEMCIS. Unfortunately, this study has already prematurely closed. Perhaps we won't have these mature data or have a proof of this agent. Another study is the Pembro plus GEMCIS versus GEMCIS. There's some rumor that this study may be presented this year in the ESMO, but let's see whether we could see the data. And for the chemotherapy, we again, as mentioned, we have the SWOG study, the GEMCIS plus or minus paclitaxel. But also we have some modified GEM plus cisplatin ongoing versus the ordinary GEM plus cisplatin in the first-line setting. Last but not least, apart from the first-line setting, and also those are immunotherapy and FGFR2 inhibitors and the conventional chemo, actually there's also highly exploratory approach, which is also ongoing in the biliary tract cancer. We may not see phase 3 data, but I think some of these early studies may potentially change our thought or prime the future phase 3. I think there's some study talking about the perioperative treatment in the, or even neoadjuvant setting in the cholangiocarcinoma. And I know there's some data, especially from Asia, China. CAR T cells may also be beneficial in some patients with a cholangiocarcinoma. Y90 plus chemo, I think recently our group has presented in the Liver Cancer Journal that the combination of Y90 to chemo, GEMCIS, may benefit some of the ICC patients. Last but not least, I think there is also some proof of concept study talking about the combination of targeted therapy and the PD-1 and PD-L1 antibody. This may potentially replace the standard chemo as the first-line treatment in the future. But this is highly exploratory. Hopefully, we have some more promising result in the future. So in conclusion, ladies and gentlemen, I think the concept of the BTC treatment has been, I would say, evolving rapidly for the past decade. We're moving from the empiric chemo now to IO plus chemo, and also the personalized treatment. And also the field, I can expect, will be very competitive. And as mentioned, the Indian country, you have a lot of patients. I think certainly you can contribute to the development of this treatment, of the treatment in BTC. And there will be a lot of research questions for us as clinicians and as clinical investigators. So last, I am showing you the night view of Hong Kong. Hopefully, after the COVID pandemic, we could meet again, either in India or in Hong Kong, to discuss more excitement on the development. So thank you very much for your attention. I'm happy to discuss or address any question later. Thank you.
Thank you, Professor Chan, for charging up the atmosphere. And with this, I think I would request you to be with us in the panel discussion also. And with that, we move on to the next part of our program, which is a debate in which to be or not to be, to give chemo only or to go chemo IO part. So we have two stalwarts here and two dear friends. The first one who's going to speak about chemo only would be Dr. Sahu, who is a senior consultant medical oncology at the Silver Line Hospital in Bhopal. Bhopal happens to be at the heart of India in the state of Madhya Pradesh. So over to you, Dr. Sahu.
Good evening, sir, and thanks for the invite. Let me see what I can make out of it. Viraj looks so happy, you know. I'll just share my slides. But I know the smile will be there for only little more time. Okay. So in the next 10 minutes, I have to speak, and I'm very clear that as we spoke, sir, it is about first line options, and that's what I'm going to speak. So with the trial of Topaz, do we need to change our way how we are going to treat our metastatic biliary tract cancers or locally recurrent inoperable, so those for on a palliative intent? So for me, it has to be chemotherapy alone. And so this is where it all started. That's how for the last decade we have been practicing a doublet chemotherapy with a GEM-CIS, and the ABC2 told us that GEM plus CIS is the standard of care, has been the standard of care, and I feel after the debate, most of us or nearly all of us will tell, okay, it still is the standard of care. So if you look at the OS of 11.7 is something which I want Viraj to very clearly mark out, and that's where the standard is. So you already have the goals very set really up, and it showed a benefit of approximately 3.5 months above standard at that point. That was GEM alone with hazards of 0.64. Now came the Topaz one, which is the topic of interest, which was published 2 months back, which was presented also this year. And this was looking at, and the professor very rightly put out what it meant and what were the inclusion criteria. But just look at it that we had to give Durva 1500 milligrams once in 3 weeks with GEM-CIS up to 8 cycles, and then the Durva could go up to 1500 milligrams once in a month. And then this is how it was, and the other arm was a placebo plus GEM-CIS followed by a placebo. So this is what it is the trial was all about, and the endpoint, as was very rightly pointed out, the primary endpoint was the overall survival. So this is the data, and if you look at it, what I want to mark you is that the hazards ratio is 0.8, but the confidence interval, I'm pretty sure of one or two more patients just missed the significance. The range, upper range, is just touching or missing 1. And this is what you have found. This is what the drug Duva as a survival has given to the addition of the gem and to a gem and cis. But this is very interesting, and all of us need to see into this graph, which the professor rightly pointed out, and look at the first 6 months, and look at how the graphs are going each other. Actually, the Duva arm is actually doing bad, and in the first 6 months, which is a chunk of 25% of our patients. Mind you, a quarter patients would be doing worse than the standard of chemotherapy couplet in the first 6 months. And that is something all of us need to remember when we are doing something like a drug like immune checkpoint, especially in India, where this drug can really cut into the pockets and really can burn houses. And that's something very, very important for all of us to remember. Now look at this and contrast to the ABC2, and look at how the graphs really separate out, and the advantage of the doublet versus what the standard was. Very clearly from the day one, you could see the graph separating out. The most interesting comes beyond that what it is. The objective response, which was the secondary endpoint, the response rate. Just remind you, keep this word of 26%, which is there as objective response, and 85%, which is there as a disease control, which actually includes the stable disease. And this is where I will come when I come to the next slide. But before that, with this addition of durvalumab with the chemotherapy, look at the median duration of response. And Viraj, this median duration of response was for those patients who had a response. So typically we have seen in other subgroups, especially lung, melanoma, RCC, those who respond, they continue to respond, and the median duration of response is way beyond, and we see 2 to 3 times that of the comparator arm. And this is somehow not being seen in this biliary tract tumor. And if you look at it, only after a year, the curves really start separating out, although on the 8th month, the separation starts. But for a good 8 months, they just do not do well enough. And in the first 6 months, the immunotherapy arm actually does worse. Compare this to the ABC2. What I told you is the response rate of 26 with the Durva GEM-CIS and the control rate of 85. And look at it. If you look at the GEM-CIS, you have a response rate of 26% with GEM-CIS in the ABC2. And you have already a stability of disease, which is actually the disease control of around 82%, nearly the same value what you saw in the Topaz one, with the addition of Durva along with the cisplatin and GEM. I just want to take you to the response rate, which also has come from our Indian colleagues in AIMS. And Dr. Sharma's paper point out that GEM plus Oxa the response rates were a staggering 30%, much more than what the Topaz once showed us. And even the GEM and S1 also looked at the data of OS, and also it looked at that this, yes, the survival was around 11.7 months. Now let's come to, is it for all patients? I've told you that I'm not impressed with the data. The OS just is significant. If the two more patients on the other side, I think they would have lost significance. Now let's come to the subgroup analysis, which is how we normally started choosing patients. And this gives us a fair idea which is a good patient for a particular regimen, which is not a good patient. Look at the scores of PDL1 less than 1. And this is approximately 40 to 45% of the patient load. And these patients do not do benefit with the combination, and the lines and the CI are wide enough. Now come to the more interesting fact. The intrahepatic cholangiocarcinoma is something that is known to be immunogenic, that is known to have more of the PDL markers, and that constituted 50% of the patient load. So basically, you run a trial, you load it with patients who are bound to or likely to do better, and they constitute 50% of the patient. We in India deal with more of gallbladder cancers. And if you look at it, they constituted 25%. And Viraj, look at this line, and I'm very sure they are the worst, and they really do not do anything. Even the small little bit, what you see, the bold dot actually sits on the middle of it. So for our Indian patients who are majorly as GCA gallbladders, this it is totally a waste of the money. For extrahepatic, there is no benefit. For the intrahepatic also, look at it, the confidence interval is 0.98, the upper limit. That's how it is. Now come down to the metastatic disease. Again, it loses significance. So basically, if you have a low PDL1 score, although the PDL1 score do not do very well, but still it's little better. The 40 to 50% patients do bad. For the gallbladder extrahepatic, they do bad. For India, gallbladder is the big problem. That's where they're doing bad. For the metastatic disease to start with, they also do not benefit. Look at comparison to what the APC2 told, and this is how I would like to see a forest plot, because most of the patients invariably will benefit from a doublet rather than the GEM. This is what a forest plot ideal should look out. And a professor told about, are we Indians Asians? And all my colleagues here who are from India know that we do not respond to any drug as our friends from the East Asians do, the Taiwan, Japan, Korea. They are something genetically very different. Most of the drugs are very respond extraordinarily differentially in a different way in this population. But look at this from the Topaz. And if you look at the rest of the world, which is approximately half the patient load, they do not benefit statistically significantly in comparison to the doublet chemotherapy. So again, it's a big no, even for a country like India, because I strongly believe we cannot compare ourselves to the data from the East Asians. Now let's come to the other so-called smaller data set, and this is from the GEM nivolumab data. And if you look at it, I just put up one data. The OS sits at exactly 11.8 months, even for the PDL1 positive patient for the combination of the Nivo plus cisplatin and gemcitabine. Basically the same data which you got from ABC2. So can we select this patient who are likely to respond to immune checkpoint? That's the more moot question which I want to answer. If you look at the data, there's very limited scarce data. The tumor mutational burden in this subset, I can tell you the keynote 158, if you look at the tumor mutational burden that came as a publication in Lancet, did not have a single patient from this gallbladder who had a, or the biliary tract, who had a high tumor mutational burden. In that subset, it was 20, more than 10, I think. So if I'm not wrong, the per megabase. In this subset or across the retrospective data in the biliary tract cancer, the high tumor mutational burden do not respond to increased responses to immune checkpoint in this subset of patients. The PDL1 slightly better. We have seen that in Topaz also, they do little better, but not convinced that the betterment is not too good for us to start changing our treatment. Other mutation is something that's very important. That is important because if you look at it, especially cholangio and the other subgroups, especially cholangio, 50% of the patient has something as a mutation. And the data for immune checkpoint with these mutations is lacking. That is something all of us have to remember. And we look at it and look at this cohort K, the MSI high, which I will definitely try to do immunotherapy. This is, if you look at it, even in the second line or third line, and look at the survival for the patient with Pembro, it is 20 months. So I would love to give a chemotherapy and give pembrolizumab for second line, reserve it for the second line if it's MSA high. That's how I would look at it, and that is how I probably will save more money for my patients. And this is what I told you, the number of mutations. And why I'm talking about this mutation, why Professor talked of the mutation is important is the survival is so extraordinarily high. And specifically, if you look at the FGFR2 fusion, the trials, the OS in the multiply failed also is around 17 to 20 months. And that's staggering after failing so many lines. And let us go further. Only known marker which I feel you could try a immune checkpoint in this subgroup of the disease where we are talking biliary tract is MSI high. And if you're doing also that, we need to remember they also have high NTRK fusions. So even I would like to ask the chairperson if he has this report with him of an NTRK fusion there with him and MSI high, and this MSI high have known to have NTRK fusions, although the MSI itself is only 2%. And look at this, what the NTRK inhibitors are doing. They're giving you a median survival of median duration of response of around 20 to 35 months. In contrast, the average response was around 6 to 8 months in the Topaz one. That is the difference what's happening. So I think some more facts to be noted. My last two slides for me. India, because we practice here, we need to talk of our country, our problems. We are stand a very low 99 rank in the income of countries across the world. So we may believe we are a developed, but I'm sorry, we are a little less than the developed nations. And in the global multidimensional poverty index, we come in the last 5 of the world. Still, we need few more years before we can start offering to every patient for 1 month difference in the survival of so-called Topaz 1 trial-like regimens. So some calculations before I end. Durvalumab, I asked the company persons also, 1500 milligrams cost you a staggering 5 lakhs per dose. So Viraj, I made some calculation, and it cost a patient 75 lakhs for the drug alone, 4 lakhs something odd for the logistics and the chemotherapy for 8 cycles, and your own professional, I know, is some 5, 6, 10 lakhs probably per annum. If you add that, it comes to 90 lakhs to 1 crore. That's what the patient is going to spend on a regimen like Topaz for 1 year. And if you would want to give it for 2 years, it's a 2 CR problem for the patient. So Viraj, I think you are going to sell a dream after this for the next 10 minutes. So I conclude, is there a rationale? Yes, there's perfectly a rationale of combining chemotherapy to the immune checkpoint. The immunogenicity increases after you do a chemotherapy to a cancer. We have seen that across tumor types. Evidence and its level, at best, I'll concede it's evolving. There is nothing that I need to change my practice. Is it applicable to all? Not at all. I'm pretty clear, Viraj. I think we are not going into every patient that lands to an OPD. Toxicity, this is one good thing that's I put it in green. A toxicity addition of the Topaz, the Durva to the chemotherapy did not do much to a toxicity. And cost benefit analysis, I don't think anyone should even bother to do this. With 1 month median OS difference in the survival, I think it is definitely a no-brainer that it is not going to be cost benefit to the patient. So take home, should wait for further data. The median OS for approximately a 1 month difference, at least to me, is not worth spending the money for the Durva. Toxicity data looks good. That's where the main thing comes through for this Topaz 1 like regimen. What I would do probably, I may be jumping the line. I would consider an NGS at least for the cholangio subgroup of patients upfront, if ideally for all the patients, and then would like to plan accordingly. So this is Viraj. You're going to see him for the next 10 minutes, I know. He is going to sell the dream. That also I'm very sure. But I'm pretty sure all the audience here, don't try Viraj and sell no dreams, because all of them are wide awake. And I'm pretty sure they are not going to sell into your dream selling. Thank you, Viraj. Thank you, sirs. Thank you, everyone. And I will leave the stage open for Viraj to start selling his so-called dreams of a crore of crores of rupees.
Thank you, Dr. Sao. before we come out of the dreamland, I hope Viraj should do justice and keep us into the reality only and keep us grounded. And of course, Sahu will have a rebuttal of a couple of minutes after that. So over to you, Viraj. Dr. Viraj is a senior consultant at the HCG group of hospitals in Ahmedabad, and he's a senior medical GI oncologist there who's practicing in medical oncology. So next 10 minutes to you, Viraj, you and your dreams. Thank you.
Thank you, Virat sir, and thank you, Sahul sir, for an excellent debate. I'm glad that you did agree that this combo is for someone, not all. And I'm going to, in next 10 minutes, show you the exact same slides what Dr. Sahu showed. And for me, this debate is about just seeing how two people can see a same data in a different way. So my job is to tell you that it is for some patients, chemotherapy for checkpoint blockade in biliary tract cancer. So we know biliary tract cancer has a very poor prognosis. This is data from SEER database that 5-year survival is virtually zero, and they don't live long. And this is the data what Dr. Sahu showed. 11.7 months is the pinnacle that we have reached with GemCis with ABC2. And we've had several attempts to better this. We've tried triplet regimens. I know AIMS, Dr. Sharma tried a FOLFIRINOX for gallbladder. We have a randomized study of FOLFIRINOX versus GemCis. It did not show any benefit, and it was published last year in JCO. While a phase 2 data of GemCis nab-paclitaxel by MD Anderson group showed median OS of 19 months. Although this is just a phase 2, we have to wait for SWOG study for a definitive answer. So the point is, we still don't have anything which beats GemCis as of now. And like Dr. Professor Chan said, that we have a lot of target-rich tumors across the board for biliary tract cancer, but they are mainly for second-line setting. And these drugs are also crazily expensive. And that means we have to do NGS for all of our patients, like the FGFR inhibitors, IDH1 inhibitors, they go for 10 lakh rupees a month today. So I don't think so. Targeting biliary tract cancer in, again, Indian setting is a smart move, and especially in the first line setting. I agree that initial results with immunotherapy were conflicting. The data of pembrolizumab and durvalumab in subsequent lines didn't show any much benefit. However, the data of nivolumab showed about a 20% response as a single agent, although some would argue that they were driven by MSI high subset. But this was the main rationale that biliary tract cancers, mainly intrahepatic cholangiocarcinoma, and for that matter, even gallbladder cancers, are slightly immunogenic, at least some form of gallbladder cancers, which I will show you that who are the ones who show hot molecular profiling, and we can exploit them with immunotherapy. So this is the Topaz 1. The best part about this study was a double-blind, multi-center global phase 3 study with overall survival. How often we see checkpoint blockades with OS as a main endpoint. And so I was glad to see this. And the important part was that in the placebo arms, full 6 months of chemotherapy was allowed. So it was not that patients got less chemotherapy. And let's see the result. They were balanced like Dr. Sahu showed. This is the same slide what Dr. Sahu showed. He wanted us to focus on the first 6 months. I agree that first 6 months there was no difference. I would not agree that they were bad. Although the pink line is below the orange lines, it was not statistically significant. But what I want to see is the last part, or the right side part, that how many of your patients are alive at 2 years. With this blockade, with this immunotherapy, at least 2 times more than 2 times people are alive if you are on durvalumab plus chemo. So we know immunotherapy, to measure the benefit of immunotherapy, we don't use medians. Even for lung cancer, the medians is at best 2 to 3 months. It's the tail of the curve, which is the selling point of any immunotherapy. And I think the long-lasting effect of immunotherapy is seen. I do agree that it is very little. So how much is little? So 1 in 8 patients. So if I were to give, like Dr. Sahu said, 6 months of therapy, that is 50 lakhs rupees for 8 people, one of them is going to go get a jackpot. So I don't know, the cost analysis is always a difficult thing because of the original molecules, but we are not here to talk about them. In couple of years, we are going to have generics, and then this talk becomes a moot point. So this is again the same slide what Dr. Sahu showed. There were 3 times more people on treatment ongoing at the data cutoff times. So that is about, you see 20 patients on GEMSIS were still on treatment, while 63 patients. So that is 40 patients out of 340 were the ones who actually got the benefit. So again, if I have to see, it's 1 in 8 patient, you are more likely to have a response ongoing. This is the slide which he showed that median duration of response is 6.4 versus 6.2. As I told you, in immunotherapy, you don't look for medians, you look for those tails. And he casually ignored the upper bracket of 17.2 months, while none of the patients crossed 9 months on treatment. So our job is, I'm not here to sell durvalumab for all patients, but definitely it's our job to find out who are these 17.2 months people, who are these people who are lying on the curve, and that should be the focus of research for next 2 to 3 years. So again, 1 in 9 patients will be on the tail if you are on durva plus chemotherapy. Something on toxicity, I'm glad that Dr. Sahu did agree that toxicity was not a problem. In fact, I would go one step further, that if you are on durva, your quality starts to improve after 6 months. As you can see, the purple line holds up while the yellow line dips. This is the reason, because the patients who were only on chemo, they were having rapid deterioration or progression of the disease, and subsequently having loss of their quality. So quality of life, overall survival. In fact, this is the classic teaching, right? That in metastatic disease, if you have one of these two, we go okay. If you have both of them, definitely it is something to consider. Now, last point, who are these patients? Who are that 1 in 8? Who is this 15% of patients who are benefiting? Apart from MSI, MSI is a no-brainer. But we had a couple of years of massive profiling of gallbladder cancer. 760 patients were profiled by Dr. Javle and MD Anderson. And what we know is that the direct DNA repair mechanism, or the HRD, is a very immunogenic tumors. And perhaps these 14 to 15% of patients are the ones which are so-called hot tumors and perhaps respond to immunotherapy. And just last month, we had a very good poster from Memorial Sloan Kettering, where they had profiled 1,000 patients of biliary tract cancer with their MSK impact. And again, the same number came out, the 17% of patients who did extremely well on immunotherapy, majority of them were HRD altered tumors, and somewhere more than TMB, more than 10. So I think it has reached NCCN. I do agree NCCN stands that it is 2B recommendation, not 2A, because our job is still not done yet. We have to find out who are these 15% of patients who would get a jackpot on immunotherapy. So I think we are not done yet, but certainly we are moving forward, and certainly something to build on. And I think so this has to be the new backbone on which we build up our further research. Thank you for your patient listening.
Thank you very much, Viraj, for bringing out the nuances of the trial. And of course, like lung cancer, the tail of the tail is always there. And 1 in 8, that is the jackpot number. How you can sift out those patients from all the patients and get the actuarial benefit from the addition of the IO, that is the million-dollar question. So before we go ahead, a couple of minutes to Dr. Sahu for his rebuttal.
Yeah, 2-3 points just. First thing is that the Viraj's one slide which I just could not get to and I could not put it is the post-treatment. And there is something that is very important to always remember: who received targeted therapy and what percentage received target therapy in the Topaz post-treatment. Viraj, I hope you remember the number. It is 3 to 4% only. So, and we have been telling, the professor has been telling that 50% of these biliary tract tumors, especially cholangio, have a target. So in this target of 50%, only 3% receive is something that is the main crux. And if that would have been done in the ideal scenario, I think the results would have been equal for both the arms. That's point number one, that I feel is a very important statement. Second is what I already told in the debate, that in this trial, it was skewed towards the patients of 50% being intrahepatic cholangio. And he also told, and I've been telling, that these are the patients who are very likely to respond to immune checkpoints. And in India, I feel the problem, what I have seen in my patient load, is more of the GB cancers. The cholangio is not the major problem for us. So with these small things, I feel in India, for this country where we have, and the drug is too costly, and we just cannot take out money out of science. If it has, science has to be affordable. And if that is not affordable, and if I have to spend 1 CR of rupees, Indian rupees per year for 1 month of median benefit, and mind you, the median duration response is some in all trials where the immune checkpoint have worked well, like lung, RCC, or melanoma, it is better. It is not similar. So that is also indication. I can agree to the PFS. The PFS looks similar. The OS looks much, much better for all these tumors. So with that, I think it's an evolving field. The future for me, what I feel like would be a targeted therapy like a plus immune checkpoints. Probably that's where we are going to go in the future. Chemotherapy might be on some for someone, but those who has a target, I think that is the combination that people are going to try. VEGF inhibitors plus the immune checkpoints also are a big future targets for the biliary tract tumor. So I think that's where I end. And Talwar sir, you gave me a pretty weak topic with a single trial, which is load in favor of Viraj. But I think I learned a lot doing this debate. Thank you, sir.
See, there are two issues. One is the OS benefit. You cannot ignore it, whether it is 1 month or whether it is 1.5 months. But definitely, as Viraj said, 1 in 8, if you can nail that 1 in 8, then I think the
can I ask one question? Even the props is there. I'm not that good at statistics.
I will ask the professor.
Yeah, the CI. I just wanted about CI. The confidence interval, if you look at the upper limit, is 0.9798. Does it sound very convincing to me when I'm using especially a drug that's worth a big chunk of the money? That's one question.
So, Professor Chan, you have heard the both sides of the coin, and both of them agree and both of them disagree on certain issues, fortunately. So I would like your opinion, couple of minutes. How do you analyze this data and what is your take?
Actually, I really enjoyed the debate. I like the points raised by both our excellent doctors. Maybe I can just make some general comments. First of all, I would like to point out that the TOPAZ-1 study actually is not a very big study, only around 600 patients. So when they design, they can only address the power is only enough to address one question, which is whether the durvalumab plus chemo improve the overall survival. So this is why when you look at the pre-planned subgroup analysis, the interval is quite wide, wider actually than a lot of robust clinical trials. I agree with you that some actually the confidence interval is very wide, but this is not because the regimen's bad or not very good. I think the reason is because when you break down into subgroup analysis, the sample size is already not enough to address a no or yes question. It just gives you a hypothesis generating. So I think in the future, I think most of the biliary tract cancer doctor wait for the MSD study, which is the pembro plus gemcis versus gemcis. The reason is because actually it's a more robust study. The sample size is much larger. And also second point is that they have recruited more patients which are non-Asian. So actually, I think it's really a deciding clinical trial. If this trial also shows similar hazard ratio, also show improvement of OS, I think the debate is over. It does improve the OS. But of course, the second question is who benefit more? But if this study turned out to be negative or just miss the alternative hypothesis, then there's a lot of debate. Really, maybe there's some heterogeneity as mentioned by our debater. maybe some subgroup benefit more, some subgroup benefit less. So there's a rumor it may be released in ESMO or ASCO GI, we don't know, but the result probably will be available somehow in the next 6 months to 1 year time. Let's see. Another minor point I forgot, I would like to mention is I fully agree, we need biomarker. But if you learn from our liver cancer, which are a bit more far away, when I think the CheckMate 459, they try to analyze any predictive biomarker. If you just look at PD-L1, I can assure you, it's not determining. You only see a slight difference. When they look at the more environmental factor, like the I think there's some signature in the inflammatory environment, like the interferon gamma or some of the environmental factors, actually is predictive. So my belief is if you just look at tissues, probably it's not robust enough to look at the environment. You need to have a set like the plasma sequencing or even the non-tumorous liver, which I think is very difficult. So I'm sure it takes long path to develop the biomarkers. This is my only 2 comments about how to interpret this trial, but I enjoy the debate a lot. Thank you for bringing me there.
Thank you, Professor. And I would request you to be in the panel discussion. And with that, we'll go to our panel discussion, and I would introduce our moderator, which is Dr. Anant Ramaswamy, who is an associate professor in the Department of Medical Oncology at the TMH Mumbai. And Anant, if you can join us. And with him, Professor Chan is there. Dr. Shekhar Patil will be there, who is a senior medical oncologist from HCG Hospital, Bangalore. Professor Atul Sharma, who is professor and HOD, Department of Medical Oncology at the All India Institute of Medical Sciences, Delhi. Dr. Bharat Rangarajan, who is Head of Services of Medical Oncology, Koval Medical Cancer Center and Hospital at Coimbatore. Dr. Amol Patel, Colonel Amol Patel is Professor in the Department of Medical Oncology at INHS Ashwini, this is Mumbai. And then Dr. Akhil Kapoor, who is Assistant Professor Medical Oncology at Tata Memorial Hospital at Varanasi. And Dr. Shefali Sardana, who is Consultant Medical Oncologist at Max Super Specialty Hospital, Saket. Sorry. So we have a good galaxy of esteemed panelists. And I would request Dr. Anand to take us through, and always look at the chat box also, because there are a lot of fireworks going on there too. Thank you, Anand. Please, all over to you.
Yeah. Good evening, everyone. At the outset, I'd like to thank Dr. Talwar and the organizers for inviting me to moderate this rather academically heavy panel. And the good part is we have representation from all parts of India almost. Maybe a little bit short on the east, but we have people from all over the country. So can I just share my screen, please?
Yes, so you can share your screen. Sir.
Okay. Okay, are my slides visible?
Yes, sir. Just make it full screen, sir.
Yeah, it's full screen now.
Yeah, done, sir. You can start.
Yeah, so the topic given to me was to add IO to chemotherapy or not. But with the permission of the chair, I modified it a little to include chemotherapy, targeted therapy, as well as IO, because I think the debate is not settled as far as we had seen, earlier. So this is what we'll try and cover over the next 40 minutes or so. We will focus on gallbladder because it is our problem in India. We will focus on the Indian scenario, and I don't think there's much more to be said on immuno because it's been covered extensively by Professor Chan as well as the debaters, but let's try and get some nuances out. So this is the first case all of you can go through. It's a 56-year-old male who presented with obstructive jaundice. His hemogram was largely acceptable. He had a bili of 9. A CT showed a GB mass with the unequivocal metastases, and a gram was done for the jaundice, and it was a type 4 block. So he underwent drainage, and at the same time a cytology was done, and that showed adenocarcinoma. Post drainage, his LFTs settled largely to acceptable limits, and post drainage he had a good ECOG PS, and he was all set for us to start treatment. So I'll start with Dr. Amol Patel, and I'll take probably 2 opinions on all these questions. So Dr. Amol, are you there?
I'm there.
Yes, Dr. Amol. So
Yeah.
quickly, the 4 questions that you have on screen. Is there a certain level of LFTs that you wait for before starting treatment? Would you consider a biopsy? And what proportion of your patients are PS0 to 1 as opposed to PS2? And do you use systemic therapy in patients with PS2?
So the first question, up to even 15 bilirubin, I don't wait for further settling down. It is a very aggressive malignancy. If you don't treat, the patient die in just 8 to 10 weeks. And already we have spent a lot of time in establishing the diagnosis. Problem is real. So I don't wait. In such situation, I just start with gemcitabine, and PS is good, then I add cisplatin too, obviously with the modified doses. Then in the current scenario, yes, majority of my patients, they go for certain kind of a trial. So biopsy is must in them. So we convince them, we do biopsy. 10 to 20% of the patients, they have this PS01. Zero is absolutely PS0, there no much actually, frankly speaking, no one, unless somebody has detected post-cholecystectomy. And last question, certainly PS2, they are the majority, PS3, they are the majority of our almost 60 to 70%, we treat them.
Okay. I think you covered all that in a short span of time. Great. Dr. Atul Sharma, is sir there?
Hi, good evening.
Good evening, sir. So I'd like to have your take. Most of the things which Dr. Amol said, even I kind of agree. But is there a certain level of LFTs that you wait for? He said he doesn't wait. Is there anything that you would wait for, or would you just start?
So I think in our personal practice, we used to start wait until the bilirubin is up to 3 or less than 3. So over a period of time, we have moved little forward, and probably now I consider it's a kind of arbitrary limit. I don't think there is any justification for yes or no. For up to 4, we will be comfortable in starting on chemotherapy. That is number one. So usually, and most of the time, we usually do not wait for the liver, not bother about much about the liver enzymes and this thing. It's the bilirubin which we are more with them. Number two, with regard to this thing, the second question is regarding the biopsy. We have a tissue diagnosis. I probably will not, unless patients wants to have the means and expenses for the either the other biomarker, which probably can be biomarker driven therapy, which we plan to, or some research purpose. That is number two. Having said that, now more and more evidence are being coming up that probably either you have the tissue repository, and it's always better to have a biopsy. You can do from, in this particular case, I understand you can do from the omentum also this thing. Third question regarding the ECOG 01 and ECOG 2, I think probably I would say only about 15-20% of the patient will present with ECOG 0 or 1. More than 50% will be about probably around 40-50% will be 2, and 1/3 of the patient will present with the ECOG 3 or ECOG 4. So the last question of yours is, you start chemotherapy for the ECOG 2? Definitely yes, because that is the majority of the patients. And so I personally prefer gemcitabine. The short answer is gemcitabine and platinum. If you want to be specific, I prefer gemcitabine and oxaliplatin based on our own data. I have shown more than once that this is the thing. Having said that, I will encourage the patients to participate into the clinical trial. And right now we have just written and probably will starting for the FOLFIRINOX compared to gem platinum, M-FOLFIRINOX.
Great. Thank you, sir. I think so. What we could understand from these answers is from 2 very senior people here is that 1, more and more people are doing a biopsy. 2, ECOG PS01 is rare. 0, I don't see. 2 is, a subgroup of patients that we see and probably treat. So those are the 2 learning points for us. Great. So for discussion's sake, a biopsy was done and it showed a moderately differentiated adeno-CA. So I'll start with Dr. Chan. Would you consider any biomarkers in this patient of gallbladder cancer? Professor Chan, please.
I think this depends on the different regions and the reimbursement criteria. I think in America or in those places where the NGS is reimbursable, I think it's now a relatively a standard now that we send the tissue for NGS and also send for the MMR, IHC or MSI PCR, depends on which method you prefer. And also we also send for HER2 FISH because sometimes NGS may miss some of the HER2 amplification in my experience. And PDL1, yes, usually we send together, although I think PDL1 is not as informative. Of course, you see very high PDL1. I think we are more inclined to give PD1, but negative, it still doesn't exclude. So I think all these we will send routinely if cost is not an issue. I'm not sure about the situation in India. For example, in Hong Kong, sometimes some of my patients could not afford. It's still not reimbursable. Then we send some selected cheaper tests like the HER2 or PDL1, hopefully to give some guidance for the treatment.
Fair enough. From going to Dr. Bharat, I know that in the South, gallbladders is a little less common, but given the scenario, what biomarkers would you consider in your setup?
In a metastatic disease, as of now, I would prefer an NGS to look for, any actionable mutations. For any patient who can afford, the test and probably the subsequent therapy. PDL1, yes or no, sometimes yes, but more on the target, looking for a target. If nothing is possible, then at least HER2 alone is something that I would look for, because we have the drug. Although we can talk about NTRK fusions, we don't have the drug easily available in India, and it may not be affordable also. So it is an issue, So, but HER2 is something that's available. So I think that we should definitely look for.
I'll take one
Same
more.
goes for FGFR. We don't have the drug.
Sure, I agree with you. I'll take one more on that. Is Shekhar Patil sir there?
Yeah.
Yes, sir. So what would you do, sir? What are the biomarkers that you consider?
At least I will do an MSI and HER2 in all my patients who are having, because those are the two areas where we have got some treatment available. But if I have got a patient who is affordable, I will do an NGS, because NTRK nowadays, we are seeing some patients NTRK positivity, and we are able to get the drug on a compassionate ground also. So I think there are some patients who would like to have all the option. I had a recently patient of IDH1 mutation, and when I discussed with the patient, they told that it cost 10 lakhs. He was ready to get the medicine. He got it and started. So we cannot just leave it like that. We have to have an open mind, and at least MSI and HER2, I will do it in all the patients. And the rest all I'll do it depending on the patient's affordability and his interest in further treatments.
Okay. So after those three opinions, the sense I'm getting is that HER2 and MSI, yes. If affordable, and NGS for all patients. If affordable, PDL1 is iffy. That's the sense I kind of got from the three answers. Great. So, it's the Indian scenario. Limited biomarkers were done, and the patient turned out to be HER2 3+. And not deficient MMR, proficient MMR. So, along with systemic therapy, would you use the HER2 positivity in your treatment paradigm initially? And I'll take an opinion from Dr. Shefali. It's HER2 positive, gallbladder. Would you use HER2 directed therapy?
Yeah, of course. I mean, I have a couple of patients in whom I got that opportunity to use anti-HER2 therapy, that is trastuzumab, along with the first line, and they did reasonably well. So I'm pretty more convinced that since we know that biliary tract tumor, we do not have much to do if we do not have a target actually. So I'm very much convinced to utilize this biomarker. Yeah.
Okay. Going to Akhil, he is at Varanasi, where they see huge numbers of gallbladder cancers. Would you use HER2 directed therapy, and why?
Yes, sir. So, sir, presently we are running a joint trial, which is a multi-central trial along with your center. So, all HER2 positive patients will be enrolled in the trial where they will get trastuzumab. So presently, we don't have data about the benefit which is there from the trastuzumab in these patients, but it is very clear that HER2 positive patients have aggressive biology. This is very, very clear, and what we can see in these patients also. Previously, also when the trial was not available, we were seeing patients who were HER2 positive and not able to receive trastuzumab. They were having very fast progression. So definitely, if a biomarker, well-established biomarker is available, it is always preferable to use the targeted treatment, and we know the tolerance is good along with the chemotherapy.
Yeah, so I mean, even though we are running the trial in HER2 positive, and we'll probably complete accrual later this year, I agree that probably they are, poor prognosis, and there's some data to say that HER3 co-expression portends an even further unfavorable prognosis. That said, there is actually no first-line data. There is absolutely no first-line data for adding trastuzumab or any anti-HER2 therapy to chemotherapy. This is some of the data that I could pull up, and for HER2, our own trial of trastuzumab plus chemo will complete the end of this year, so we should be able to present it next year. But all the data is only in second line. So with that caveat, I'd like to ask Dr. Amol here, because he's published some work on HER2 positive. What do you do, sir? Dr. Amol?
Dr.
Yeah.
Anand, if Dr. Amol completes, then I would like to ask one question regarding that thing. That is what my practical experience on HER2 is also there. So in second line, probably it does not work. And that is true with the progression on trastuzumab plus chemo also. None of my patients did fairly well once they progressed beyond first line with trastuzumab and chemo.
Okay.
So I don't know what is the reason. So is the HER2 expression loss sometimes causing that issue, or it is something else which is troubling? But that is true, I think, on that scenario.
Sure. Point well taken. But Dr. Amol, would you like to add something?
Yeah, so with my study, which is a prospective study, and it was a huge,
there
I
it
would
is.
say, in terms of germline, or basically genetic testing, it was foundation in 50 patients. So there are very interesting points I would like to tell you here is HER2 positivity in females beyond 55, 60 years. What are the patients I have? They have a very unique disease. No jaundice, there is peritoneal seeding in all three cases. And in fact, the diagnosis was made after the laparotomy, the laparoscopic biopsy, and in that HER2 came positive. In both two of the patients, they did well, I would say 18 months, but I had the opportunity to look for the mechanisms of resistance. So out of these two patients, they had concurrent HER2 mutations. And I was, as a mandatory protocol in my study, the trastuzumab only allowed in second line. So with the initial, what are the regimen we have, whether it is paclitaxel or the gemcitabine or paclitaxel or capox, whatever. But the trastuzumab, for just 2 months, again, the patients started having the CA99 elevation in just 6 to 8 weeks or 10 weeks time. And then with the background of the similar mutations which are there in the breast cancer also, and there are reports of lapatinib working. So I used to add lapatinib with nab-paclitaxel plus trastuzumab. And in those patients, they did fairly well. So there is a lot of issues here in gallbladder. If you see the report, it's not just HER2. HER2 is always with the something is there, whether it is HER2 mutation or there is HER3 amplification. In fact, there were patients who had only HER3 mutation along with it, and along with the HER2 new amplification and HER3 mutation. And there was some data from Japan that the HER3 mutation patient, they do well. So this kind of a complex situation are there. So it is not just one, umbrella which is going to cover it. It is, we need to know when we are studying the HER2 new. I absolutely agree with you, Anand. It is a very, very aggressive disease. In fact, one of the patient here, again from the Varanasi, we just did the biopsy, HER2 new came. He just asked me, we just want to go home. the stenting was done, we will come after 2 weeks. He didn't come, came back to the hospital. When I called back after 4 weeks, भाई क्या हुआ नहीं आए? बोले सर वो तो अचानक बीमारी बढ़ने लगी और इधर ही एडमिट किया and whatever, patient died. So there are multiple things in this. One point, I will come to PDL1 experience with this also. But certainly I advise you, Anand, because we need to see more of the tumor environment, other mechanisms of resistance, and then we would be better able to do justice for her to target in this situation.
Point taken, sir. Point taken. I think it's an aggressive subset, and we are all clutching at straws here, basically, and they do progress very fast. I'll just take Dr. Chan's opinion on this. How often do you use HER2-directed therapy in your patients upfront? Do you consider it?
Yeah, yes. If I really see evidence of HER2 amplifications, I do use it because I do think, say, I used to see it in gallbladder cancer, and because the prognosis is known to not very good, although the data are robust, data are lacking, but I still use it because of poor prognosis. And my experience is quite good. We don't see additional toxicity too much, and my patients usually have more durable responses. But I do have one minor comment on this case, but maybe you can educate me on this. I'm actually a bit surprised to see there are two phenotypes. One is HER2 3+, and also
that was a mistake. It is a proficient MMR. That's a misprint.
Oh, okay.
Yeah.
That's okay, because it's very rare to have two phenotypes. So if I saw that, I will definitely double check. But okay, that's a typo. Thank you.
That's a typo. Yeah. So I think Dr. Amol's points are well taken, and we all would want to use anti-HER2 therapy, even if the evidence is a little iffy on that. So just to twist the case around a little, the same patient, actually had, again, a proficient MMR status and HER2 1+. They are not affordable for durvalumab, as is common in our country. However, ECOG PS is 1, and he's willing for all chemotherapeutic options. So I'll go to Atul sir and ask him, what would your treatment of choice be and why? Atul Sharma sir.
Just give me a minute. I need to read it.
So I just twisted the situation around, sir, saying that the HER2 is negative and it is MSI stable, not deficient as in the slide, and durvalumab is not feasible, but otherwise all set for treatment. What would you do and why?
All right. So basically, based on this thing data, that option, of course, if affordability is not an issue, you said this is deficient MMR status.
No, sir, proficient. That's a typo, sir.
Oh, this is typo. Okay.
Yes,
sorry.
yes.
All right. Then the options will be either in a clinical trial using the modified FOLFIRINOX based, I think, comparative study, or gemcitabine oxaliplatin.
Okay, right, sir. Dr. Bharat, what would your options be? The patient is PS1, willing for treatment, not feasible for durvalumab.
Most likely option 1, and in some highly selected patients, option 3. Gemcisplatin or gemcisplatin nab-paclitaxel, but that's only after a lot of discussion in some selected patients.
Okay. I think, we do agree that while Gemcis has been the standard for the last decade, I think Gemox is there's a phase 3 trial from India. Atul Sharma sir was the PI, where they showed near equivalence. And I think this was alluded to earlier by Professor Chan as well. The Gemcis nab-pacli, the survival data is quite nice. The survival is around 19 months with almost doubling of response rates. So in a patient with PS1, if not in a trial, I think an option that's up and coming is Gemcis nab-pacli. I agree with that.
Dr. Anand,
Can I ask a question?
Yes, sir.
Because you are, sorry.
We have a lot of the Indian colleagues sitting here, and this thing, just wanted to learn basically in their experience. Many of us are using chemotherapy, gem, platinum compound, and this thing. What is the median survival they are getting? Because many of the Western studies, unfortunately, I haven't been able to breach this thing, wall of this thing, 1 year survival in any of our study.
So I'll do a quick head count. So we'll start from Shefali. what do you think is the median survival you see on an average? As Sir said, what would you say?
Yeah, so on an average, I mean 1.5 to 2 years, what we generally encounter. So I take into account with the good performance status. So good performance status up to ECOG 1, 2 I take, okay, because 2 generally respond once we do the biliary drainage. So I take it into account.
Shekhar Patil, sir? What would...
Where does Shepali works? 1 to 2 year.
1 to 2 year median OS, including all things, sir. So I'm
कहाँ काम करते हैं? Just sorry, don't worry my question.
Max Saket. Yeah.
Oh, okay, Max Saket. Okay.
Okay. Akhil, what your thoughts?
Yes, sir, we have done a formal analysis. It was intention to treat analysis, including all the patients, and our median OS is 7 months.
Absolutely. And can I say here, Anand, I am breaking in. I am breaking.
Okay, I'll just put that into perspective. We had someone say 7 months, and if I jump into the fray, I would say something of the similar sort, 7 to 9 months. We have someone who says 1.5 to 2 years. That's a wide range. I'll take one more opinion, Dr. Bharat.
I would say around 12 to 14 months.
Okay.
But remember, Anand, the sort of patients you see and the sort and the number of patients we see in private setting is hugely different, both financial wise and nutrition wise, especially nutrition wise.
I completely agree. That is why I say median 1.5. So, because I mean, the poor PS nutrition wise is very less likely that we encounter. I mean, they are more of a better profile. Nutrition does play a role, actually.
Atul sir, does that
maybe?
Yeah. I'll just take half a minute and add to that. Even in our FOLFIRINOX study, modified FOLFIRINOX, where we use, which was limited to only ECOG 0 and 1, we were not able to reach 1 year survival.
Yes.
And they all got this thing, prophylactic GCSF. There were no mortality. Most of them completed planned treatment, but still the survival was, I think, probably 310 or 15 days. So it was less than, I think, just 10.5 months or something around.
So
can I add something here?
Dr. Sahu was saying basically because of the predominant population of the biliary tract, so the cholangiocarcinoma, which biologically is a different disease than gallbladder cancer, that we need to keep in mind.
So a couple of points to add here. One, I think the cholangiocarcinoma point by Atul sir is well made. We had recently published our outcomes on cholangio, and there the survivals crossed a year. It was around 12 to 13 months. But gallbladder, if a patient of mine crosses a year, I'm kind of happy. It's not the norm. It's not the norm is what I think. But yes, we do have exceptions, and nutrition and economy do play a major role. That point is well taken. So for the purposes of discussion, this patient received 8 cycles of GemCis. He had good response after 4, and at 8 as well, he has a maintained response. He has good quality of life now. He's PS1, no debilitating neuropathy or other symptoms. What will you do next? And I'll start here with Amol Patel, sir. Dr. Amol, what would you do?
Sorry, I just missed.
Sure. So the patient received 8 cycles of GemCis. He had response at 4, maintained response at 8. He has good quality of life now. His PS is 1, no neuropathy. He's asking you, what do I do next?
He is maintaining the.
Yes, he has maintained response. Yes.
Just observation. Give maintenance.
Sorry?
I observe.
Okay. Great.
Option 1.
Okay, great. I'll take one more opinion on that. Shekhar Patil, sir, what would you do?
Hello.
Yes, sir.
You are able to hear, sir? Yes. Hello.
Yes, sir. You are audible.
Yeah. I also will keep under observation and see it. Whenever there is a progression, I'll think about the second lines.
Okay. Professor Chan, what do you do in your practice of trial?
Depends on I think every option is feasible, depends on the age of the patient and performance status. For some elderly, I think usually they suffer a lot during the chemo, and I think it's very fair to observe and give them some break from follow-up and the treatment. But for some really young patients with good organ function, I do give sometimes a maintenance treatment like capecitabine to them, hopefully to improve the progression-free survival. The last point I would like to mention, this is not a standard. Actually, after the ASCO GI TOPAZ 1 data, there's some thoughts that maybe the divided survival benefit after the median OS, after 6 months, probably is contributed by the maintenance use of durvalumab. So there's some thought that we may skip the use of durvalumab in the first 6 months and then use it as a maintenance. Of course, this is not validated in the trial, it's not studied, but there's some discussion that maybe the durvalumab may be one of the choice of maintenance treatment, but we need high-level evidence to prove that. Okay. But this is a hot topic, and we need further data. Yeah.
Akhil, I'll take your opinion because you see so many of them. What do you do?
Sir, yes. As again, we share the same platform. We are doing a randomized trial where we are enrolling patients in a maintenance study, bevacizumab varlotinib maintenance versus observation.
Okay. So this is some of the data
I could enroll every patient.
This is some of the data I could pull up. One is from our institute at Tata, where this is all retrospective data, and as Professor Chan said, it is a good topic for a trial, but there is no prospective evidence. This one was 396 patients. There was some benefit in OS. Later data from Seoul, South Korea said there is no benefit in OS. So I think it's a heads or tails, answer. And I think it is based on an individual clinician and physician decision rather than any hard data. This is the trial that Dr. Akhil had referred to. After 6 months of chemo, we are randomizing to observation versus bevacizumab and erlotinib, a non-chemo maintenance. We should be completing accrual at the end of the year. And it looks encouraging is, the least I could say. Great. So I'll now shift to cholangio because there are many targets available. This is a 49-year-old lady with hypothyroidism who presented with weight loss, anorexia, and abdominal discomfort. Her entire workup was done. She had liver-predominant disease, but with metastatic nodal sites as well. It's essentially an IHCC. So again, back to my older question, the biomarkers here. Dr. Atul, what would you do in these patients, assuming that they are feasible for all treatment options? Is Atul sir there?
Yeah, I am there. The questions beyond. So,
yes,
can you go back to the history?
So it's a 49-year-old lady.
Yeah.
Yeah.
So now move to this thing, and this is the cholangio.
Yes, sir.
So move to the next slide.
Yes, sir.
So are you saying that biomarkers have been done? No biomarkers beyond MSI?
So I'm asking you what you will do, sir.
So of course I'll do whatever is possible, go for the NGS and probably do whatever the available this thing, depending, because we have a lot of this thing, some data, number of agents for the cholangio available. Okay. Target driven or biomarker driven agents are available. So we'll go for the NGS basically. Of course, IDH and FGFR2.
Okay. Dr. Amol, what would you do in your practice in a patient with intrahepatic cholangio with all options feasible, no financial constraints?
Obviously, I would do everything.
Okay. So when you say everything, how strong do you think is the evidence to do things like a TMB and PDL1? Dr. Amol? Okay. I'll go to the this one. So I agree that we would try and do an NGS. This is a paper published 2 years back, where in IHCCs, you have, the IDH1 and the FGFR2 fusions. With regard to, biomarkers for immunotherapy, I think this was extensively discussed. Dr. Atul, any thoughts on biomarkers for immune checkpoint inhibitors? I mean, these are some which I could pull out, but would you go with any of those biomarkers to predict a response, or would you just say, let's start chemo plus immuno?
So we will definitely be going for the biomarker based at basically to select the agent other than the chemotherapy. And in case available and the means are available, it is showing, then of course I don't mind going for immunotherapy. So basically the simple answer is that of course this is the one disease or scenario where the biomarker should be done basically for immune checkpoint inhibitors.
Okay. But sir, how convinced are you on the prognostic or predictive value of anything other than MSI in biliary tract tumors? That is my question. MSI, yes, I mean that is an easy one.
Yes, basically whatever the data we are coming at this thing basically through the NGS at this thing, there's no question about MSI. But regarding the PDL1, so I probably personally think that the PDL1 probably is the one which probably, even because the gallbladder cancer as such is there is the dismal prognosis. Nothing beyond this thing chemotherapy has been showing other than the durvalumab and this thing. So given the chance, even though this thing, whatever you have shown the predict possibly response to and this thing for unfavorable prognosis for the PDL1, I do not hesitate to go for the PDL1. And in case it is probably high, then probably these are the some scenario where I probably, if the patient is affording economic, not a problem, will go for immune based. I use basically.
Okay. Dr. Bharat, your thoughts on TMB? So Dr. Atul has told me, okay, PDL1 he may not consider, but he will do it. Your thoughts on TMB in biliary tract? Because TMB is slowly making its way into guidelines. Now, gastric cancers, they're saying can consider TMB. Some other tumors, they are saying consider TMB. In biliary tract, do you think TMB will guide you, not guide you?
See, we can do the test, Anant. That is, it's not a question of doing the test. We can do the test for patients who are going to be able to afford taking an immunotherapy. You can do the test. But even if you look at the keynote, which looked at all the TNB, the best responses were less than 60%. It's not as if, you have one biomarker and you can definitely predict a response. But if you're going to do the drug, it's always good to, as Dr. Atul said, look at the PDL1, look at the TMB, look at the MSI. At least you have some sort of a clue on whether this patient is going to respond or not. But if the patient is never going to take up immunotherapy, then I would not, ask for these tests. So that I think it's what the patient really affords. But if they can afford, I will look at all this, at least to my mind, to be predictive to a certain extent.
Okay. Yeah, I agree with you. I mean, if a patient can take durvalumab, then I would do the testing. It would help me explain whether he might or might not benefit, given the caveats that I think Professor Atul and you had mentioned. Yeah, but I would not consider it mandatory or not push for it. That's
absolutely right. Not.
Yeah. I think this is the study, I mean, I think has been discussed ad nauseum over the last 40 minutes. Everyone has pinpointed the flaws and the highlights. To me, I think one surprising thing was that in the study, MSI high, the data was missing in more than 50% of patients. I am a little surprised at that. I don't know why that happened. And to me, in this study, majority of the benefits were seen with maintenance. I think, as Dr. Sahu said, largely the curves are similar for 4 to 6 months, and then the maintenance probably kicks in. Professor Chan, any thoughts on that?
I think all of you have very nicely summarized and discussed the data, and I don't know. I think one of the reasons why the MSI phenotype is not available is because for the extrahepatic, usually it's quite difficult to obtain adequate tissues or cytology. I think this is a common problem in extrahepatic tissue tumor. But I think even you have MSI data, my experience is MSI phenotype is not common, very common in cholangiocarcinoma in general. My experience is probably lower than 4% overall. And so I think we certainly need more other biomarkers other than the known biomarkers, like what have been discussed, PDL1, TMB. I think in the future, this will be a very hot topic. Maybe liquid biopsy or some other like inflammatory gene signature. I think this probably will contribute more and to the overall picture.
Yeah, I agree. The only thing is that I worry a little bit about the lack of benefit in gallbladder cancers because that's the disease we see. But then, as you said, this is all hypothesis generating. The study is not powered for these analyses. So yeah, that's something. So this patient actually received Gemcis durvalumab, then did well for approximately 9 months, after which there was unequivocal progression. She still had ECOG PS1 and adequate organ function. So my question is, Atul sir, what proportion of your patients are fit for second line therapy?
I would say around 15-20%.
Okay, sir.
If you include the ECOG2 also.
Yes, sir. For sure, I'll include ECOG2. Dr. Shefali?
Yeah, so 30% approximately would go for a second line chemotherapy.
Okay. Shekhar Patil, sir, how many of your patients go for second line?
Around 25 to 30%.
Great. And assuming all the biomarkers are negative, Shekhar sir, what would you choose? IDH1 is not mutated, FGFR fusion's not seen, proficient MMR.
Generally, we prefer to go for PIFU based treatment, Folfox or Folfiri or single agent capecitabine, one of the three things.
Okay, sir. Akhil, what do you do in your practice? Is Akhil there? I think Akhil is not there. Okay. Dr. Bharat, what do you use as second line treatment?
Most likely Folfox. If Folfox is not feasible due to technical reason, Capox.
Okay. Why the doublet?
See, only 30% of patients actually reach, 25 or 30% of patients are actually reaching second line therapy. And these are patients who are in good shape, good PS. Only then you're considering. At that point of time, these are the patients who would do well and live longer if you treat them aggressively. The rest of the 70, 75 are never going to reach that point. So if they reach that point, definitely a doublet is what I would go. Usually, because I would have used gemcitabine cisplatin in the first line, either Folfox or Capox in the second line.
Atul sir, I'll take one more on this. Atul sir, what do you do in patients who are fit for second line?
I think I'll go for GB Select.
Yeah, so I mean that's just to we did this trial in India.
Single agent iron.
Yeah, Dr. Amol, what would you do? Yeah, I mean we did this trial in India. We had predominantly GBC patients, and we didn't see a benefit with the doublet. And so. Dr. Amol, your voice is getting cut. Sorry. So, I mean, just to carry on that point, I mean, it's not, this was done in AIMS and TMH, and we didn't see a benefit with the doublet. Even if you do use the doublet, the difference in survival compared to active symptom control is a month in ABC6. So my point is that in advanced cancers, we normally go from 1 drug to 2 drug to 3 drug. So, I would be conservative in treating these patients, but outcomes are not great. I think that is something that we all realize. The biomarkers, yes, IDH1 and FGFR2. Any Indian experience with using FGFR2 inhibitors? Anyone? I've not used it. Anyone has any experience? Dr.
So,
Shefali,
Dr. Anant, I think in intrahepatic cholangiomas, there is a trial going on with Dr. Nirmal Raut in Mumbai. So one of my patients got enrolled who had FGFR2 fusion in intrahepatic cholangio, who had a stable disease post 6 cycle Gemcis followed by radiation. So still non-metastatic after that. But it was undissectable disease, so she got enrolled. So I think that trial is going on, and quite a couple of patients are. But that trial is for adafitinib. That is not for pamigatinib.
Yeah. Professor Chan, your experience with using any of these drugs, because they're not available on a large scale in India as yet.
Fortunately, I have experience, especially I have used 2 patients ivosidenib, and I've 1 patient I think few in the clinical trial saying futibatinib, and I have 1 patient pamigatinib. So far, the experience is the toxicity-wise is very well tolerated. Of course, they do have some specific toxicity like the HFR2. We do see a phosphate issue. We need to give a phosphate binder. but usually the patient tolerate the drug very well. We don't see any big problem. Ivosidenib is also very well tolerated with some only marrow or fatigue. But the problem of these TKI is not surprisingly, you do see benefit, but or prolonged SD. But what you do expect one day, if as a monotherapy, after like 6 months, 7 months, they will have PD again, resistant clone. I think this is a general problem. So I agree with what has been discussed. Probably we need combination to prolong this PFS. Otherwise, it won't change the whole picture, even you found this biomarker. Yeah.
Yeah. Yeah, I think at least in intrahepatic cholangiocarcinomas, there is worldwide data, and I think the FGFR, there are now, I think, 6, which are 3 are approved, 3 are on the way. And in gallbladder, at least in Indian setup, we are a little excited about her too. I think that's what something that we are looking at. And
Dr. Anand, can I ask one more question, please?
Please do.
So, I was really looking into if we see the GEMSIS data versus GEM alone, 11.7 months reported, okay, median OS. And then 30% of the patients if reach the second line, and the worst OS in the trial you showed was 6 months, approximately, median OS. So why are we surprised to have that median OS total in, that biliary tract patients not to be 1.5 years? I was really keen to understand that what is actually making the difference, and we were surprised enough to have that idea. So 30% patients reaching second line and worst OS, you see the graph which you are showing, the table. So that is why I was surprised to understand actually.
Okay, okay. I think so. One is that as we treat these cancers, and others can chip in, it is not one disease. I
agree.
We're all clear that, the GBCs respond better but survive less. The cholangios probably respond lesser but survive more. And then nutrition, ECOG, and all that comes into play. And I think if you do an analysis now in Indian patients, compared to the 8-9 months, maybe survivals are a little better. But 1.5, 2 years to me, I would be very
not
happy.
Exactly 2 years, 2 years in couple of patients, but on an average, yes, of course, I would not mind accepting that it would be, median OS of 1.5, not 7 months. So,
So, yeah,
it is
those
something
are the
difficult
patients,
to accept for me.
Those are the patients that,
50%,
push us to treat these patients more. I agree. So with that, I think, we reached the end of our 45 minutes. I would like to thank all the panelists for their active participation. I learned a lot. And thank you for your patient listening. Back to Talwar, sir.
Thank you.
Thank you very much.
It's a very invigorating discussion which Anand has got into us. And we started with the addition of IO, and now we've gone through the whole gamut in first line and second line. And the best part here was in this panel discussion was that we were discussing our own data. So I think that's the way to go forward, because our data is very different from the Caucasians and from the other races. Races do matter, and you cannot extrapolate one to the other. So I guess I will thank the speaker, especially Professor Stephen Chan, the debaters, moderator Dr. Anand, and of course the esteemed panelists. And I think we will close this session, and it will be a pleasure to have this kind of discussion. So I thank everyone, and of course the logistics team by Tarun. Not to say that it was flawless. So thank you once again, and have a great evening. And take care.
Thank you. Yeah.
So thank you so much, Dr. Vineet sir, and everyone for participating. So from the organizing team, my colleague Surbi, thank you. Good night. Stay safe and stay blessed. Good night, sir.
Thank you. Bye.
Thank you.